Great pleasure to have you, Marcela, in our webinars of the Reconnect. You're a special guest, and this is a webinar for healthcare professionals, although patients are also invited to come, and of course, to have questions, and then it would be available for everyone who wants to hear on the site, as Eleonora was saying. I do have 3 slides that I'm supposed to share. They're here, so let me just share them. To do it again, so sorry. I am Raquel Faria. I am a member of the Relapsing Polychondritis working group of the Reconnect, and I am actually an internal medicine consultant in Porto, Centro Hospitalar Universitário de Santo António, and it's really a great pleasure to have you here. So, you are our speaker, Marcelo Ferrada, and you are from the AMS NIH researcher, and of course you can talk a little bit about you while you are going to talk about when to think of VEXAS in the patient with relapsing polychondritis. It's a kind of a new thing, although almost 3 years old, but we all need to hear from you your experience with this. Eleonora already came across the things about the webinar. It will be recorded. It will be on a YouTube channel and on the site, and you can do any question on the question Q&A or on the chat from Zoom, and they are both down on the screen as you want to, and they're going to be addressed on the end of the presentation. So the floor is yours. I'm going to interrupt my sharing.
Okay, I can share. Should I share now? Yeah.
Yes. As you want to.
All right. Give me 1 second. I just want to see. Okay, so this is you guys cannot see the slides, right? Can you? No. Let me see.
Seeing them as your presentation format. So
this is let me see if we could do this one different. No. Give me 1 second. Oh, no, that's not what I want to do. All right. Yeah, now can you see it?
Yeah, perfect. It's perfect now, yes.
All right, okay. Well, thank you so much for giving me the opportunity to talk about VEXAS and relapsing polychondritis. Really, truly an honor. And my name is Marcela Ferrara. I work at NIH under NIAMS, and I'm going to get started. So I have no disclosures, nothing to disclose financially. However, I do have to disclose that I am Colombian and I speak loud and fast, and this is just because of where I'm coming from. So I'm not really yelling. And I also want to disclose that the work that I do is actually, to me, not my work, but it's more my passion. I would like to start with a case. So this is a 32-year-old male that had intermittent left wrist MCP and right knee arthritis. He also had costochondritis that included the xiphoid process, difficulty swallowing, and shortness of breath. And he was found to have a swollen epiglottis. And he also had intermittent episodes of ear and nose pain, redness, and swelling. And this is the picture of the patient that I just described. And this is the first case that have been recorded in the literature of a patient with relapsing polychondritis. And this article was in German, and my husband in act of love translated this article for me, and I was able to read it completely, which was amazing. And at the end of the article, the author concluded that this patient maybe was having all of these symptoms because he was drinking a lot of beer. He happened to be a brewer and was drinking about 5 liters or 8 liters of beer per day. I don't think that it was the beer because so far we have not been able to find any connection. So rest assured with the beer drinking, I do not think that it is associated with relapsing polychondritis. And I just want to highlight that although the disease always been recognized as being a disease affecting the ear mainly, this is way more than swollen ears. Yes, the ears is an important aspect of the disease, but this is a systemic condition, and I'm going to go over some of the main clinical manifestations that are very important to remember in patients with a suspected diagnosis of relapsing polychondritis. So I wanted to take the opportunity to talk about the organ involvement in relapsing polychondritis. So it does affect the cartilage. So this is an example of an ear swelling. As you could see, it is a little bit swollen and red, and it's not that tomato ear. The nose, a little bit of redness at the tip of the nose, but patients usually, when they have nose chondritis, they will describe pain at the bridge of the nose, and sometimes you can see much on the physical exam. So you really need to rely on what the patients are describing to you. This is an example of dactylitis. So patients with RP have a lot of musculoskeletal symptoms. Many joints can get involved, large, small, and it's more than the synovium and the joint. I suspect that this has been described as being non-erosive because it's more the tissue around the joints. This is an example of subglottic stenosis, and we have a lot of cartilage in the neck that can get inflamed, and patients with inflammation in these structures can have different kind of symptoms. I'm going to go over that a little bit. And this is an example of lower airway damage. So an example of tracheomalacia, and then this is the collapse of the anterior aspect of the trachea. And it's also good to remember, because I think that sometimes we forget about the anatomy, that the distal aspect, see that the bronchi, not distally, but medium distal, have little tiny pieces of cartilage that I believe can get inflamed. And that's why many patients that have airway chondritis or airway type of RP can have a diagnosis of adult onset asthma that is difficult to treat because of this. And it's actually, I don't think that is actually asthma. The eyes can also get inflamed. The most common manifestation that we have seen is episcleritis. However, when the patients have scleritis, it's very severe. Central nervous system, mainly limbic encephalitis, inner ear, heart valves, vasculature, and skin. Now, these particular organs, I made this slide before we discovered VEXAS, and as I keep seeing patients with VEXAS, I am starting to recognize that this organ involvement is actually more common in patients with VEXAS. So I suspect that what we have seen in the literature in terms of central nervous involvement and heart valve disease and skin is probably patients actually with a diagnosis of VEXAS. So how do we diagnose relapsing polychondritis? Well, it is a purely clinical diagnosis, and it needs to include these clinical symptoms, right? So it's bilateral auricular chondritis and nasal cartilage inflammation, respiratory tract chondritis, non-erosive seronegative polyarthritis, ocular inflammation, and audiovestibular involvement. And McAdams was the first person that came up with the clinical diagnosis of RP. And then he said, if you have 3 of these 6, then you have relapsing polychondritis. And then Damianis modified this by including a biopsy, 1 clinical symptom and a biopsy, or 2 clinical symptoms and response to steroids or Dapsone. And then Dapsone, because this was done in the 1970s. So The problem with this is that we do not have clear definitions of what is auricular chondritis or any of this, right? So what is auricular chondritis? Is it damage? Is it redness? Is it pain? Is it swelling? So I think that that is one of the major issues because I think that many physicians are expecting to see a giant like tomato ear when sometimes the ear chondritis could be a little bit more subtle, right? So I think that we need to work in defining this organ involvement since the diagnosis is purely clinical. The other problem with this is that this has not been validated and was done in very small cohorts. So this is something that we definitely need to work on. And how difficult it is to diagnose RP? Well, we did a study that included an international survey of patients with RP, and we found that 54% of the patients had to see more than 3 physicians prior to establishing a diagnosis, and that 55% of the patients went to the emergency room prior to a diagnosis of RP, and the symptoms that they had when they went to the emergency room include ear chondritis, shortness of breath, pleuritic chest pain, and costochondritis. Now, if you go to emergency room with any of these symptoms, it's very hard that the patients are going to be able to get a diagnosis of RP, but I think that these symptoms are important to keep in mind because it's telling us what are the symptoms that are more severe, right? That will bring patients to the emergency room. And that is why it's so important to do a very complete review of systems and ask the questions specifically about these particular symptoms, because sometimes the patients are not going to tell the physician, for example, about the ear pain. And we also found in this same study that there were some factors associated with delay in diagnosis. And one of them was having a diagnosis of fibromyalgia. And I think that this is super important for physicians to recognize, because I think that there is a particular bias for patients when they have a diagnosis of fibromyalgia. And then once that get into their diagnosis list, some of the patients get dismissed because of all the other symptoms that they may have. And because some of the symptoms in RP are so different and unique and a little bit strange, and I'm going to go over that in the next few slides, patients get dismissed. And I think that this is a very important aspect that that every physician should keep in mind. You know, when you have a patient with a diagnosis of fibromyalgia, did you really rule out any other possible condition? And these patients actually should be followed very closely, because I don't think that we have an understanding or knowledge of what is the amount of patients that have a diagnosis, initial diagnosis of fibromyalgia, that then develop more symptoms and became a patient with a clear diagnosis of a rheumatologic disease. So basically, relapsing polychondritis is a systemic inflammatory condition that is rare. However, I do not think that relapsing polychondritis is rare. I really don't. I think that we just need to learn more about this disease and recognize the symptoms and the pattern of organ involvement, so then patients can actually get diagnosed. And it does have a predilection for cartilage, but again, super important to remember that the disease is systemic and it is very heterogeneous. Since I first started learning about this condition, I realized that it was very heterogeneous and that it was probably more than one disease, because it was so different. And I am not the only one that have been thinking about this disease like that, because before I start learning about this condition, there were a lot of experts and physicians and researchers that were looking at this disease, trying to figure this out as well. And that included, sorry, the animation didn't work the way that I wanted. But these in here, I'm trying to show the different subgroups that have been identified in RP. So for example, our friends from France had a very important, super important article of a very large number of patients, including 142 patients, and they wanted to find different subgroups, because I believe that they also recognize the heterogeneity. And by doing cluster analysis in this very large group of patients, they found 3 different subgroups. And I am going to talk about this a little bit more close to the end of this presentation. Shimizu, our friends from Japan, also did the same thing. However, they took a different approach to analyzing their data. So basically what they did is that they did a survey, and then they distributed this survey to physicians that were taking care of patients with relapsing polychondritis. And instead of using an unbiased approach, meaning that they put the variables and the computer found the different subgroups, what he did was that because he's so knowledgeable about relapsing polychondritis, then he basically divided the patients before analyzing, right? So then he said, we're going to have a group that is going to include only the patients that have auricular involvement, only the patients that have respiratory involvement, and an overlap. And then we also tried to do the same thing in the study that we did with a survey, like this was patients answering the survey. And we also did a pre-defined analysis. So we included patients that had mainly joint involvement, ear and nose involvement, and respiratory. But I wanted to highlight that we all thought about the respiratory subgroup, right? So it's there, and it's always been there, which I think that this is a different type it has a different type of mechanism leading to the respiratory involvement. And then we again wanted to do this, but we wanted to use the data that we have been collecting at NIH prospectively, and we did something similar to what the French colleagues did, but because this was a smaller group of patients, only included 73 patients, we did something called latent class analysis, which is also a clustering method that you use for partitioning data. And we found, or the computer found, like 3 different subgroups again, right? So we have the type 2, type 1, type 2, and type 3. And let me explain to you this figure that I found beautiful. So this was actually made by one of our patients with RP. And then the darker the color, the higher the percentage of organ involvement. Now, the variables that I chose to include in this analysis were variables that were very objective. Therefore, they were more damage. So it was kind of like late disease. But if you could see here, type 1 is the typical RP that physicians will remember from medical school, right? So these are patients that have cauliflower ear, subglottic stenosis, saranal deformity, and tracheomalacia, and severe eye disease. The type 2, again, we found the respiratory subgroup. So these are patients that have mainly lower airway disease with tracheomalacia and bronchomalacia, and the ear involvement is not as severe or as typical as the patients that have type 1. And the type 3, which is the majority of the patients, were patients that do not have significant damage that you could see. However, they do have ear and a lot of joint involvement. However, these patients had a significant disability, and they also require a lot of treatment. And the patients that are in type 3 have a lot of other symptoms. So this is the more heterogeneous subgroup. And what we have found in these patients is that they have a lot of other symptoms that are not really related to cartilaginous involvement. And these patients, many of these patients have POTS. They also have the arthralgias without arthritis, Raynaud's, dry eyes, dry mouth, without having antibodies positive for Sjogren's, a lot of myalgias, muscle weakness, without having any antibodies telling us that they have myositis, ophthalmoplegia, and a lot of GI manifestations. So my last theory about this group is that if this is due to something, for example, mitochondrial dysfunction. This is very preliminary, and I wanted to highlight that, and this is just a hypothesis at the moment. but we are really trying to figure out what could be the mechanism leading to the patients in the type 3 subgroup that have all of these symptoms. The other thing that we found in the type 3 is all the other conditions that are associated with RP. And that include MAGIC syndrome, right? So MAGIC syndrome is mouth and genital ulcers with inflammation of cartilage. So this is basically having relapsing polychondritis and Behçet's disease. And why they decided to call it MAGIC? I have no idea, because it's not really magic. You know, relapsing polychondritis and Behçet's, no magic. The person that described this is at UCSD. He currently does research in rheumatoid arthritis, but when I talked to him about this, he was like, yeah, you know, we were just having some beers and then trying to come up with a catchy name. So that's why they call it MAGIC. And what we found in patients with MAGIC syndrome in our cohort is that there were no differences in terms of the race, sex, and age of symptom onset or age at diagnosis. However, these patients had a significant delay in diagnosis. And I suspect that is because these patients also have other symptoms that are not typical of relapsing polychondritis or very cartilaginous like, right? Because then again, what you're expecting to see is the tomato ear and all of these symptoms that sometimes they are not as objective as we like, right, as physicians. So it's important to keep that in mind. And we also look at the different clinical manifestations that these patients can have when you compare patients with MAGIC syndrome and patients without MAGIC syndrome. And we found a difference, right? So patients with MAGIC syndrome had more GI symptoms, they have more cutaneous involvement, more DVTs, aortitis, they have more airway chondritis, nose chondritis, and they have, of course, the oral and genital ulcers, and they have more uveitis and retinitis. So a lot of the Behçet's-like and vascular-like symptoms that you can find in this particular subgroup. And why this is very important is because these patients can have aortitis, right? So if you have a patient that have relapsing polychondritis and is not like a typical ear and nose, and then this patient is also having Raynaud's, and then you ask about the oral and the genital ulcers, make sure that they don't have aortitis. It's super important. And I know that is something that maybe people will think that yes, it make like common sense, right? But you really need to ask your patients about the genital ulcers, because they won't contribute this history. So you really need to ask and then explain to the patients why this is important, and then why this is not because you're suspecting an STD or anything like that, but that is important that you know about this because of the implications in terms of organ involvement, because many patients will be ashamed of saying that they have ulcers in the genitals, but it's an important symptom. And then the respiratory subtype is common in all the subgroups, as I mentioned. So I made this figure with colors, so it's easier. So this is the Shimizu study that I showed you before. So they have the ear and the overlap between the respiratory. This is our type 1, type 2, and type 3. And this is the French super good study that had the hematologic and the mild. They call it mild, but I want to highlight that they call it mild because these patients didn't die, right? And they survived for many years. But I don't want people to believe that because it's called mild, the patients have a mild disease, because these patients also have, again, significant exposure to immunomodulators, and then some of these patients can have significant disability and morbidity. So this is important to keep in mind. And then I suspect that the patients that they call mild are very similar to our type 3, that it is the most heterogeneous and systemic, right? They have all of these like weird stuff. And because of the airway subgroup, I want to take some time to discuss about this. So the prevalence when you take a look at the different studies, it's between 20 to 50%. Wang and collaborators did a very nice study where they compared the patients that have airway involvement without airway involvement. And what is amazing to me is that when you see the main articles in the literature of large cohorts of patients with relapsing polychondritis, we keep seeing the same. It's not really changing. So although the disease is heterogeneous, we keep seeing the same subgroups. So Wang et al. Described the respiratory subgroup, and it was very similar to what we have seen. So these patients had a higher incidence of costochondritis, a previous diagnosis of asthma. They tend to be younger, they have more ICU admissions, and they have delay in diagnosis. Patients that have upper airway involvement have obviously subglottic stenosis, and patients that have the lower type, the type 2, have more focal and diffuse malacia. And patients that have malacia actually have more disability than patients that have subglottic stenosis, because patients that have subglottic stenosis have a tracheostomy, right? So they're able to breathe, whereas patients that have malacia is hard, right, to treat. So that's why it's super important to recognize this and then try to treat it early before there is airway damage. And I wanted to take also the opportunity here to go over the cartilage anatomy, because I think that, I mean, I forgot, right? I mean, we just like study anatomy so long time ago. But there is a giant piece of cartilage in the anterior aspect of the neck, and that is the thyroid cartilage. And this cartilage can get inflamed. So now there's a problem with this. And the problem is that you can't see it. Again, as physicians, we always want to see things, right? It's easier when you have something that is objective, right? You go and then you see like, oh, it's inflamed. Yes, I see it. The problem with this is that you can't see it because it's super thin. So we tried, right? So you do a CT scan, you do MRI, and then you can see it. And then you cannot see it by direct visualization. Maybe in the future, we will be able to see this with ultrasound. But this is problematic because when it gets inflamed, it can be very painful. And then the patients will tell you, I have pain right here. And then sometimes it gets a little bit swollen, but sometimes you can really see. Another giant piece of cartilage is the epiglottis. And some of the symptoms I suspect could be due to this. So difficulty swallowing and that like low sensation, and the arytenoids that you can see due to direct visualization. And in some patients, we have been able to correlate this with disease activity. However, it's difficult because if you have GERD, the arytenoids are going to look a little bit swollen, right? And then if you're taking steroids, then maybe you have GERD, so it is a little bit tricky. And the other cartilage that is important is the cricoid cartilage, that is what is going to lead to the subglottic stenosis. And here I'm just showing you some of the symptoms that I was mentioning to you before. So you can have anterior neck pain because of the thyroid cartilage. The throat pain could be either because of the epiglottis, and the hoarseness. This is a symptom that I'm still trying to figure it out what is the mechanism, because patients have a lot of hoarseness and then you do direct visualization and you see nothing. Right, so is the tissues around the throat, or is because of the maybe the other possibilities associated with muscle weakness? I'm not entirely sure. So we have to work in finding why, because a lot of patients with RP will have hoarseness. This is an example of a nose of an ulcer. So the ulcers in the nose of patients with relapsing polychondritis is very different than what you would see in GPA. In GPA, you see like more like very angry inflammation. In RP, is more at the septum and is more like a little bit crossing. And they do have septal perforations, but patients that I've seen with septal perforation do not have saddle nose deformity. The patients that I've seen with saddle nose deformity do not have septal perforation. It's more like the cartilage melted. Very different than what you see in GPA. So it's important to differentiate the two diseases. And this is an example of a normal upper airway visualization due to direct laryngoscopy. This is the arytenoids, this is the subglottic space, and these are the vocal cords. And this is a patient with severe severe subglottic stenosis. Now, if we take a look at the lower airway, this is the trachea, right? So then this is the cartilaginous aspect of the trachea, and this is the posterior wall. And then there are two things that can happen here that are going to decrease the diameter of the trachea and are going to be associated, this is going to be associated with shortness of breath. One is the damage of the cartilage, right? That it can go invaginate here or the lateral walls. And the other part is when the posterior wall collapses, and you call that excessive dynamic airway collapse. This happens to all of us physiologically. This will go inside when you're expiring. But if this goes inside more than 50%, then you can have difficulty breathing. We have seen changes in this posterior wall in terms of how much it invaginates secondary to air trapping, which I think that it makes sense because it's a change in pressures, right, from the airway. And I also want to highlight that patients with airway disease can have a diagnosis of adult onset asthma difficult to treat. And I believe that this is because of the little tiny pieces of cartilage that actually can get inflamed. And for some reason, we also have been seeing decrease in the DLCO, but I am not entirely sure what is exactly the mechanism. We're trying to make a correlation with air trapping because we have not seen pulmonary infiltrates or increase in right-sided pressures that could explain this. And this is an example of a dynamic CT scan that we do at NIH. So we perform a video where you could actually see the posterior wall, and then you can see the anterior wall here, and this patient also has air trapping. So I think that RP is more than one disease, right? And this is what all the people that study RP, I think that could maybe think the same thing that I'm thinking. And that's why we try to isolate the different subgroups to make it more homogeneous groups that you can actually study. But patients with RP need a multidisciplinary care, right? Because again, it's systemic. You don't know which is going to be the subgroup that this patient is going to be on. Because at the beginning, I think that that could be difficult to figure it out, you know, unless they have the tremendous inflammation and the Saddle-Lowe's deformity. I think that you need to follow these patients very closely and do a complete evaluation, you know, to make sure that you don't miss anything and they can receive the best care. So the summary for this first part of the talk is that relapsing polychondritis is a disease with multiple clinical manifestations, including isolated airway chondritis. There is a lot of work that we need to do, but I know that there is a lot of people that are very interested in working together, doing all of this research and developing new tools to help patients with RP. Awareness and recognitions are super important for early diagnosis because it's a clinical diagnosis at the moment, so you really need to have a pattern of organ involvement recognition, and ear chondritis can happen late in the disease, and it can have a very different range of clinical presentations and characteristics that they are yet to be defined. And MAGIC syndrome could be its own entity. And now I'm going to move on to the other part of this talk. And historically, we have known the hematologic subgroup in RP. And again, the French study, I think that is super important because they identified this. They identified this subgroup in 2016. And this is what they found in their cluster analysis. So look at this. They found that these patients had no remission, they have more thrombosis, they were men, they had no laryngeal involvement, they were older, they die more, they have cutaneous involvement, general symptoms such as fever, fatigue, and all of that, and they have MDS. Sounds familiar, right? So I think that they basically identified VEXAS syndrome in that cluster analysis, and now we know what is the cause, right? Which is mutations in the UBA1 gene. So the next one is a funny slide. So because I wanted to talk, spend half of a minute talking a little bit about the history of VEXAS and then why I got involved so no long time ago in a galaxy very close to us called NIH. Peter Grayson, which is my friend and mentor, evaluated a long time ago 3 patients that had very similar clinical manifestations, but he couldn't find a specific cause, a commonality, you know, in these particular patients to have the same, like to put them all together. And then David Beck, which is also one of my friends, super smart guy. He's a internal medicine geneticist currently at NYU, came to NIH working under Dr. Kastner's lab, and he had a particular interest in the ubiquitin pathway. And he found the mutation, the mutations in the same gene in those 3 patients. And how I got involved is because we were in a lab meeting, and then Peter said, "Oh, I think that we may have found a new disease." And then one of these patients had chondritis, and I was like, "What? Chondritis?" And then when they described these patients, I was like, "Wait a second, we have patients in our cohort that look like that, and they never really make sense to me because of this, and that. Let's test these patients," and boom, they were positive for the mutation. But what David did is that he basically took data from patients from the NHDRI and the Undiagnosed Disease Program, and then he included patients from the periodic fever database, and that included 2,560 patients. Again, he was looking at the ubiquitination gene ontology, and then he used these 3 parameters to identify those genes. So having a PLI more than 0.9, being a novel variant based on NOMAD, and having sharing the variance between the cases. And that is how he found those first 3 patients that then got expanded to 25, and that is what we published in the New England. And what is VEXAS? So VEXAS is a new genetically defined syndrome due to somatic mutations in UBA1 gene. And these patients have an overlap between systemic inflammatory symptoms and hematologic features. And the disease, unfortunately, can be severe, refractory, and often fatal. And what does it mean? So V is because they have vacuoles in the bone marrow. Not all the patients have vacuoles, but most of them have vacuoles. And the E is because the mutation leads to the lack of the E1 enzyme in the cytoplasm. X because is X-linked, A because of the autoinflammatory aspects of the disease, and S because the mutations are somatic. And patients with VEXAS have different clinical diagnoses, and that's why I think that is super important for I think that like rheumatologists, hematologists, dermatologists, primary care basically know about this condition because they meet criteria for different diagnoses. The initial clinical diagnosis that this patient had in our first report included relapsing polychondritis, sweet syndrome, polyarteritis nodosa, and giant cell arteritis. However, since the first description, there have been many case reports of patients with other clinical diagnoses having the mutation leading to VEXAS, including lupus, ANCA-associated vasculitis, rheumatoid arthritis, so super important. And we decided to look at our cohort of patients with RP because the majority of the patients had ear and nose chondritis. And then we found at that time that 8% of the patients with RP had VEXAS in our cohort. So basically, this is the cause of like about 8 to 12 based on the literature, because there is new reports looking at this, including the Japanese colleagues were look at exactly the same question. So it's basically the cause of RP in about 10%, which is amazing. These are the common clinical manifestations of patients with VEXAS: fever, skin involvement, lots of skin involvement. So they have leukocytoclastic vasculitis, they have sweet syndrome. We have been able to identify the correlation between sweet syndrome and patients that have the leucine, the change in the codon for leucine. They have a lot of sweet syndrome. They have pulmonary infiltrates that could be acute and chronic. Acutely, super important that they get treated with high doses of steroids, of course, after ruling out infection and all of that, but they can get into trouble right? And getting intubated because of this. And of course, ear and nose chondritis and DVTs and PEs. And this is an example of chondritis. And then this patient gets always very excited every time that I show his picture, because he, this is the picture that we put in the New England manuscript, and he was super excited that his nose was famous. So I'll let him know that I show you all his nose, and he will be happy about that. And in terms of the lung involvement, we were able to demonstrate in one particular patient that the acute involvement was due to neutrophilic pneumonitis. But again, there have been more reports about the lung involvement in patients with VEXAS, including a French report that described the different findings in CT scans and included some fibrosis and different specific patterns. There is also a report from Mayo that look at this in a small case series. So we're still learning, you know, about the patterns of lung involvement in patients with VEXAS. And again, it can be acute and chronic. So super important that you do PFTs in these patients and CT scans. When we look at the different characteristics of patients with VEXAS, RP, and compare them with patients with RP, we found that these patients were mainly males, and they have age of disease onset later as compared with patients with RP. And this is just what we found when we compare the patients with RP without the mutation and patients with VEXAS RP. So then they have more lung involvement than airway. However, the Japanese group looked at this and they found a few patients with RP VEXAS that had airway involvement. After that report, I have been doing dynamic CT scans in all the patients that we have seen at NIH with VEXAS, which is close to 50, and I only have found thickening of the trachea in 2 patients. So it can happen, but I think that is a significant smaller percentage than what you see in patients with RP without VEXAS. And what I've seen in patients with VEXAS RP is more thickening of the trachea rather than like damage, like tracheomalacia. And then when we compare the different clinical symptoms, we found that they were different, right? So patients with VEXAS RP, which is the red, they have more fever, typical ear chondritis, meaning like the red, super angry nose. They have pulmonary infiltrates, and they have lots of skin involvement, where our patients that have RP, they have more airway involvement, and they have more joint involvement. And of course, patients with VEXAS RP also have unprovoked DVTs. Very important also to keep this in mind. And these patients have more complications, so they have increasing mortality, they have more ICU admissions, more DVTs, and more diagnosis of MDS. And because of the high percentage of patients with RP having VEXAS, we developed an algorithm based on our data, and we found that in a male patient with ear and nose chondritis, if that patient had an MCV more than 100 and platelet less than 200, this patient is going to likely have VEXAS. These have been expanded though, and then they have been looking at other characteristics, which I think that is very important to keep in mind. In here, we only included patients that had chondritis, but there is a particular subgroup of patients with VEXAS that do not have chondritis. Those are all the patients that have the veiling codon. Those are the ones that we have seen mainly without chondritis, and the patients that have the most inflammation. So if you see a patient that is having a lot of very unspecific symptoms that you could see in VEXAS, so like periorbital swelling, they also tend to have a lot of jaw swelling and involvement. I don't know exactly why, and skin involvement, elevated inflammatory markers, and elevated MCV, and you should consider this patient to be tested for VEXAS for sure. Important to get tested, right? Because of prognosis and treatment. And these patients have a very high mortality. So in this cohort that we included 83 patients, we found that 25% of these patients died during the study period. However, in this study, we included the 25 patients that we initially described, and many of these patients were found like diagnosed post-mortem. There's something that we need to evaluate prospectively. But because those patients died so much, my next question was, why why is the mortality so high? And then looking at that particular question, we found that patients that have valine, the patients that have tremendous amount of inflammation, die more than the other two patients. And the other factors that we found associated with mortality was transfusion dependence, and ER chondritis was a protective finding. Now, I mean, I don't think that if you have ER chondritis, then you're protected. No, I think that the reason that we found that patients that had ER chondritis maybe live longer is because ER chondritis is an early symptom, right? So that's why we found, we had this finding. I suspect that is the reason. In terms of treatment for VEXAS, it depends on the stage of the disease, right? Because they all have the mutation, they are all similar between each other, but still, there is heterogeneity within that group, right? Because then you have, and I think that there is an association in terms of the clinical manifestations and the changes in the codon, right? You have the most common ones are valine, leucine, and threonine. For example, patients that have valine have, again, more inflammation. Patients that have threonine are the most common patients, and they have more chondritis. And patients with leucine have a lot of skin involvement, including neutrophilic infiltrates, and these patients tend to have more hematologic manifestations. So it's going to depend on the hematologic manifestations and inflammatory features. However, there is always, most of the time, an overlap, and the hematologic manifestations tend to progress to bone marrow failure. So that's why it's important to think about when is the timing for transplant. I'm jumping from stage of the disease to transplant because this is the likely curative treatment. Most of the patients require steroids, and again, some of the patients require very high doses of steroids, and because of that, they have a lot of complications. And the steroid-sparing agents that we have been able to see at least partial effect include tocilizumab. For ruxolitinib, I think that ruxolitinib may work to decrease the inflammatory features in VEXAS. However, these patients need a very high dose, and because of that, they can have side effects due to the ruxolitinib. And azacitidine is more for patients that have, I mean, we still need to a lot to study, right, to learn from these. But azacitidine, there is some case series that have shown to this medication to be effective, particularly for those patients that have other mutations that can lead to MDS, like DNMT3 or TET2. And it's super important to consider, right? And then this makes sense. Will probably make sense to everybody, but I think that it's important to highlight that because they have a late age of disease onset, they have a lot of issues. Super important to manage all of these complications that they have, particularly the coronary artery disease. We've seen this a lot because of the steroids. So this is something that we cannot forget to evaluate in these patients, and also prophylaxis for PCP and herpes, particularly VCV. They have more PCP and more VCV reactivation that could be terrible, because then you have is very bad, and then you can have all these neurological issues afterwards. So important to do prophylaxis and bone health. So always get a DEXA scan and do any treatment that is going to be necessary based on the DEXA scan. And the anticoagulation, we haven't come up with a particular recommendation for this, but these patients have DVTs and PEs, particularly at the beginning of the disease. So we believe that this is secondary to the inflammatory process. So they need multidisciplinary care, and super important that we work together. We need to work together, and I apologize for not putting here the primary care, but it has to be a team that communicate and come up with recommendations together. And so in summary, the phenotype and genotype continues to expand in VEXAS. 8% of the patients with RP have VEXAS for now, but we'll see what happens. Patients with VEXAS need a multidisciplinary team. Bone marrow transplant is likely curative. And when do you test? Again, I discussed this briefly, but if you have a patient that have inflammation of no etiology, likely males, but as you know, there is cases in the literature of females also having VEXAS. And then if this patient have elevated inflammatory markers, and even if it's just slightly elevation of the MCV, consider testing this patient for VEXAS. And I have two more slides that I will be sharing with you. And at the beginning of the talk, I said that I am not yelling and I am Colombian. So I hope I didn't yell at you too much. And the other disclosure that I had was that this is not my work, but my passion. And I want to share a last case with you that is a little bit personal. So this is a 36-year-old woman with ongoing dry cough and shortness of breath, and PFTs show air trapping. However, the patient did not have response to bronchodilators. She had improved the symptoms with very high doses of steroids. And when she tried to taper the steroids, she had costochondritis, anterior neck pain, bilateral knee swelling, and the review of systems was positive for ear pain, redness, nose redness and swelling, voice changes, and intermittent episodes of arthritis, dizziness, and syncopal episodes. And this is actually me. So this is a picture of me on my first ICU admission, many ICU admissions to come after that. And what I have learned, that is how I got interested in relapsing polychondritis, and then how I was able to have the amazing opportunity to be part of the discovery of VEXAS. I was a critical care infectious diseases physician, and I was diagnosed with relapsing polychondritis and decided to go back and became a rheumatologist, so I could study this disease and treat patients with this condition. And what I have learned is that when you see like a mountain that it looks that is very hard to climb, if you have a lot of collaboration and friends that support you, and networking, super important, because there is a lot of smart people around the world and you need help. You can never do anything alone. And with very hard work, this is supposed to be meaning hard work, right? Balancing is like hard work. Then you could really be successful, you know, for at the end of the day, for the best of the patients, because that is what we do, right? So I like to acknowledge everybody at NIH, and particularly our patients, but at NIAMS, Peter Grayson, which is my mentor and friend, Wendy Goodspeed, which is my research nurse. I could not survive without Wendy. And then David Beck, Dr. Kastner, and Ivona. And I will be happy to answer any questions.
Thank you so much, Marcela. Thank you. Actually, it was supposed to be an HCP webinar, but we knew that we would share, you would share, and we thank you so much for sharing your own experience. It's really important for all the patients to know that it's hard, but you can get it if everyone helps. Thank you so much. So if anyone has questions, we do have a couple of minutes to discuss things. I wanted to ask you something that you didn't mention. I'm absolutely sure because it's a time issue. So if you have a suspicion on RP patients to have VEXAS, which test would you run?
Yeah.
Which genetic test?
I don't know what is the, I think that it will be super important to find out what is the available test that you guys have in the United States. This test has become commercial, so you could actually send it to a company called GTC, and then you just fill the form, and then it's included in the cytopenia panel. So you will be looking for mutations in the UBA1 gene, particularly at position P-MED41.
So we, at least in Portugal, but also in Europe, we have been discussing, as you know, for the international task force, and we have commercially available Sanger sequencing for exon 3 and 16 for UBA1. We have commercially available also PCR for the 3 most common mutations. And in some research centers, we are also doing NGS for high penetrance for all the gene of UBA1. At a first step, you would ask for the PCR for the most common, or would you ask for the Sanger?
Yeah, I think that is what I will do. And then, because then that will give you like probably faster, straightforward answer. However, right, if it's negative, you should totally send it for further testing. Yeah.
We have 2 questions. One of them is, I think it's intuitive for people who knows our works, somatic mosaicism, but it's not intuitive for everyone else. So if you say that VEXAS is a genetic disease, is it hereditary? Can you please explain it a little bit? Why does VEXAS is not hereditary, being a genetic disease?
Oh, sure. So it is not hereditary because the mutations are somatic. So that means that these mutations are acquired through your life. We are all mutants. We just don't know that. So we all have mutations over life because of many things, right? Environments and exposure, all of this. So we all have mutations that we acquire through our life, and these happen to be a mutation that is acquired. Why this happened, we don't know yet, and when is it happen, also we don't know. I mean, we don't know the timing, right?
But we do know that's only in the bone marrow that is happening.
Correct.
And yeah. Can you please explain why it is more frequent in males than in women?
Because it's X-linked.
So yeah. We do have, women have 2 X chromosomes, men have only 1. So if it's mutant in men, they are less able to overcome the mutation. So that's why, but it happens in females also.
Right. And then I think that we still have to learn about the clinical manifestations of this disease, and particularly in other populations. Like I think, for example, in Latin America, we do not have an understanding of this. And there is different groups that we really need to spend time understanding the patients with this condition.
We have 2 more questions. One is Monica Benudici, that I think for the question, she's a RP patient, and she's saying that her daughter gets red hairs and cheeks quite often, and she's worried about it. And what do you think about RP being inherited?
Yeah, so I think that, as I mentioned during this presentation, I think that as we continue to learn about this condition, we may find different other genetic causes. So far, we have not been able to identify, an hereditary a cause of this disease, and I think that we just need to keep looking.
Thank you. We have another question. Do you think that in an RP patient having high pancreatic amylase or high serum histamine has anything to do with RP?
I have not seen that in patients with RP. The only patients that I have seen with elevated amylase, meaning pancreatitis, is because of side effects of medication. So if a patient with suspected RP has pancreatitis, I think that the cause of that needs to be evaluated, including IgG4.
We are a little bit above time. Thank you so much. It was really comprehensive and really clear cut through to understand RP more and VEXAS in RP. I do have a final question if you're available to.
I have time.
Did you find in your cohort RP patients with hematological features that were negative for UBA1?
Yes, Yeah, and then the interesting thing is very good question. What I have found in these patients is more, I don't know if they have more a type of hemolytic intermittent, is intermittent. So they will have not elevated MCV, but anemia, you know, episodes of anemia, and is intermittent. And then it goes away, and then it comes back, and it goes away, and it's not something that stays like patients that have VEXAS or progress. Why this is happening, I'm not entirely sure, because it is sometimes a little bit challenging to evaluate patients when they are flaring, you know, and then trend that over time. But I have seen that, yes.
Do you think it could be another somatic mosaicism, like VEXAS-like syndrome, that could be responsible for that, or you don't think?
We haven't been able to find that. Again, I think that there's still a lot of work, you know, that we need to do. I do suspect that there is a subgroup of patients with a diagnosis of relapsing polychondritis, the ones that do not have significant damage and all these other symptoms, that they have something more at a molecular level. And that's why it's so hard to find something in a large scale, meaning anatomical damage or anatomical findings. So you will have all of these symptoms, and then you know that there is something wrong, right? But you can't see it. And I think that we can see it because it's either at a microvascular level or molecular level.
Okay. Thank you so much. It was really a pleasure to have you on the ERN Reconnect webinars. Hope to see you in another time. Thank you so much for all of you that have been listening, and for all the other HCPN patients that would be able to learn more from you on the YouTube after this recording. Thank you so much.
Thank you. Bye.
Bye.